So this is Codeman's own paper. So he says first, for improvement, you have to admit your complications, then analyze your complications, and then see if they are controllable. Only then you will actually have a protocol where you can say this is right and that is wrong. And we don't have it. We are all different, all tears are different, all patients are different, all surgeons are different. But the principles of cuff tear will always remain the same. You have to recognize the tear pattern. The rows are not important. You have to adequately release the cuff so that you can do a tension-free repair of the mobilized tendon. The initial strength of fixation should be excellent. Otherwise, this is going to go for early failure. These three things are very important in any type of cuff tear, not how many anchors or how many rows you put. They matter, but what matters more is the multiple fixation points to increase the stability. So we have moved on to anchors which have 3 loads of sutures and so forth. As told by Burkhardt himself, the most important factor to increase cuff healing is to achieve stable fixation of the tendon and the bone interface. We all know the single row. We all started doing cuff repair with the single row. And in the single row, we know that the SCOI technique is excellent, where you have a mattress and a simple beyond. Now, recently, with the triple loadeds, the better SCOI technique has come out, and they say that this is one of the best techniques. There are literatures to and for single row and double row. I wouldn't go into details. Talking about double row with this in mind, this works in the suspension cable principle. So you have more footprint to cover with the double row. The whole of the GT is covered with cuff. It maximizes uniform compression of the tendon against the footprint. So what does this do? This will minimize the motion in the tendon-bone interface, thereby increasing the healing rate. So this is your suspension bridge, and that is how your double row works. Now, this is what happens with single row when you depend on single row in bones which are osteoporotic. You see this in your old age ladies. When you're putting your anchor, everything looks good. But when you're tying your knot, especially in these old ladies who's got osteoporosis, sometimes you overzealously tie your knot. This is an attempted single row repair, as you can see. And then that happens. It is not wrong with the anchor. The anchor is a good anchor. The angle of fixation was good. But this just happens if your bones are osteoporotic. So single row good. Okay, then. What happens with the lateral row? You can still have some problems with lateral row. So this was a lateral row. Things look well reduced. Angle to begin with is not excellent, but reasonably okay. Most of us will accept this angle. It goes in well. You can see now. And then everything pulls out. So lateral row is also not without complications. These are my personal complications. I've had these in single rows and double rows. I think the single most important factor with the double row is its role as the rescue anchor or the offload anchor. So your supraspinatus will pull your anchor medially, and then there might be some shake in your medial row anchor. Now when you do a lateral row anchor, it stabilizes the shake because the lateral row will pull the anchor on the other direction. So this minimizes the load on the anchor. So this is a attempted single row repair. You can see the SCOI technique. You can see the simple being tied. But when I'm tying, I feel that the suture anchor is not great. You feel the small jerk happening there. So what I do, instead of cutting it off, I quickly do a lateral row there to take off the load of this anchor, the medial row anchor, and so that this anchor goes on, this cuff goes on to heal without failing. So biology is very important. You can do it in both single row and double row. I'll take 20 seconds more. The verdict: medial row stability is poor, osteoporosis, go for double row. We know that. Initial fixation strength, biomechanics proven, double row. Yes, you go for it. But big tears, you want to medialize your footprint. You really don't want to stretch your cuff and pull it down to the lateral row. Go for single row. Easy coverage, you have good mobilization, you want to increase your footprint coverage, go for double row. Healing, you can do the crimson duvet, single row is good. But biomechanically stronger, you can still do crimson duvet and biology in double row, so points for both. We really don't know. Cost efficacy, single row, cheaper, but a well-done double row is also cost effective. We have studies because there is retear rates with single row. But I think this is a wrong war that we are fighting. It is not about single row or double row. It is about biology and stress-free multiple suture point fixations. So both of you win. Thank you.